So again, thank you all for being here. This is something that I wanted to do in person, but given that the circumstances of the world have changed, I wanted to bring this virtual. I really have a passion for teaching. As some of you may know, I really am into pain science, and I've taken a lot of continuing education courses on pain science throughout the years. And some of my biggest role models in the field of physical therapy and rehab come from pain science backgrounds. So I put together a presentation to kind of give us all practical applications of how we can manage clients that have chronic pain, because they're the most difficult to manage in terms of just all the complexities that go into working with this demographic, and it's just incredibly costly how we're managing them currently. And I wanted to give us all solutions on how we can combat this. So I'm going to share my screen. I do not want, what am I doing? Not that, not that. There we go. All right. So what I hope for everyone to gain from this is an understanding of what pain is, which I'm sure most of you are familiar with now that the curriculums are incorporating the biopsychosocial approach and understanding everything that's involved in that. Then I want to really delve deeply into the subjective examination of the chronic pain patient. So basically, when a patient steps into the door and we're greeting them, what are things that we can consider verbally and non-verbally that can help assist in the management of this patient? Understanding that we all have biases, both you and the patient, and that beliefs of treatment, beliefs and perceptions about treatment, pain can be varied. So just learning how to negotiate all of those factors. And then after we talk about the subjective component, we'll talk about how we can help the chronic pain patient through a skilled therapeutic exercise approach and incorporating pain neuroscience principles into our rehab program. And at the end, I do have a case study from a patient who was my patient about 2 years ago that I think ties in nicely to this webinar. So hopefully we can have some time at the end for a Q&A and talking through that case study. So I don't want to talk too much about what pain is, but pain has originated maybe even before Rene Descartes in the 15th century, but definitely he's one of the earliest thinkers to talk about pain. And basically he came up with this circuit, this picture that you see on the right, that basically was like, if I touch something that's hot, my brain is going to process it as being hot because tissue damage is actually occurring because my body is processing that heat is, is a noxious stimulus. And that theory had withstood the test of time for many centuries. So it was actually a very good finding by Descartes to at least get the process going that this is how pain circuitry works. But in the late 90s, Lozer and Melzack brought into the equation that pain can actually be the result of actual or potential tissue damage. So raising the question that does tissue injury actually need to occur in order to have pain? So in a couple of years later, Mosley and Butler, two of my favorite pain scientists and the authors of Explain Pain, brought into light this concept of pain being an output and pain requiring consciousness in order to manifest. So they took this potential tissue damage concept and brought into this thing where our body, our brain is making a judgment about what is toxic and what is not toxic, what is dangerous and what is not dangerous. And that pain experience is our brain's best guess about what will be a good response in the presence of danger. And that still tends to be the best pain definition that I've found. If you guys have an updated one, I'd love to hear about it. So I adapted this from Jared Maynard's lecture, which I highly recommend if you guys have a moment. A clinical athlete is giving this away for free right now. And Jared Maynard does a very nice job talking about pain science. And this is from Jared Hall in that lecture, basically depicting how information comes from the environment and our tissues. Our brain scrutinizes it and decides whether to inhibit or create an output of the best judgment into our back into our muscles and our motor system, and then that creates this cycle of events, this feedback loop of brain processing information from the periphery and creating this efferent response. So talking about the phases of pain, you first have nociception. Nociception is what is giving us the information that something is dangerous or painful. So basically everything's happening in the periphery at this point. And if at this stage, it's very easily modifiable what's happening at the ion channel. So in the presence of pain, you have ion receptor channel changes. Our sensitivities to pain start to slow down, but at this point, not so much. It's when we start getting into peripheral tissue damage and inflammation where you have larger scale changes at the ion channels, but still to the degree where you can modify it fairly easily. It's when these changes manifest for long periods of time. So greater than 3 months is usually what's categorized as chronic, is when those thresholds at the ion channels that need to propagate an action potential to the brain tend to lower, because we're on this heightened alert. So it takes less of a stimulus in order to reproduce this pain response. And at this point, because there's cortical changes in the brain and a lot of what we call smudging of different cortices of the brain, it's difficult to reverse the process that this patient is experiencing, this negative pain experience, and it keeps perpetuating. So now I want to talk a little bit about subjective and physical exam, because I think this is arguably the most important component of our physical therapy treatment. I think that nailing the subjective exam is going to get you better long-term outcomes, even if you're the most skilled manual therapist or exercise movement specialist. I think if you don't nail the subjective, you're setting you and the patient up for failure. So some of you might have seen this diagram before. I adapted this from an article, but I like it quite a bit because it basically puts the ICF model into perspective, where we have our body function and structure component of the ICF model, which is encompassing this biomedical approach, but you also take into consideration personal and environmental factors that are contributing to someone's pain response. Thinking about someone's capacity to manage everything that is being thrown at them and contributors to pain, I think this diagram does a nice job summing it all up. But even though we know that pain isn't strictly biomedical anymore, strictly based off of tissue damage, we still, and I'm generalizing when I say this as we all, because we don't, but many of us still lean on pathoanatomy to justify people who are experiencing pain. So we have an increase in therapy prescription, injections, medication prescription, all that is really expensive. And oftentimes we know now that we don't need it. And we know we don't need it because research says we don't need it. In one study, only 8 to 15% of people who had lower back pain actually had an identifiable diagnosis on imaging. So most of the people in that study who complained of lower back pain didn't actually have any significant tissue damage. Moving on to how prevalent it is to have tissue damage in the first place, and it's incredibly so. And I talk about lower back pain because it is the most widely studied in the context of chronic pain, but people as young as 29 years old have a 20 to 30% chance of having disc height loss or protrusion. Now, I know that I might fall in that category. I've had about 2 bouts of lower back pain already, and I am breathing and I lift things, and there's a possibility that I have that damage. And it steadily increases over time to the point where if we're all lucky enough to make it to 80 years old, 80 years of age, we'll have about a 90% chance or greater that we're going to have some sort of degenerative change. So tissue damage, degenerative change in itself is not necessarily correlated with back pain. And for those people who hang their hat on tissue damage correlating with pain, we actually know now that the larger the lesion, the greater potential we have to heal. So if you have a larger disc bulge or protrusion or even a sequestration, and I remember all these little jelly donut models when I was in school, the larger sequestration actually has a greater potential to heal than the lesser tissue damage. So if someone's really hanging their hat on pathoanatomy, I like to use that to sort of still get them on the right track and thinking that they are capable of being healed, whether they initially hold the belief that tissue damage and pain are interrelated, which I'll delve into it a little bit further. So we're talking about chronic low back pain because, again, this is the most expensive, most difficult to treat, and low back pain causes a lot of negative factors. Aside from worrying that it's not going to go away and being hopeless because you've just been in pain for so long, lower back pain can place strain on a family. You can, as a parent, you might not be able to do things with your children. You might not be able to perform daily household chores. It might limit your ability to perform your occupation, and certain occupations are certainly more physically demanding than others, and you might be at risk of losing work because you can't perform your job, which causes more family strain, and so on and so forth. I know many patients who have lower back pain, particularly in their older years, sometimes are fearful of even leaving their apartments. Well, here in New York, their apartments, but in other parts of the country, maybe their homes, because the thought of sitting in a theater, sitting at dinner for an extended period of time and not being able to walk home is a risk that they're not willing to take. So it keeps them away from being socially active and seeing their friends. And one thing about lower back pain, when it's chronic and it's being mismanaged in the way that I spoke about before, is people start to lose faith in us as healthcare providers. You know, they come to us seeking guidance and expecting things to get better, but if they keep having unsuccessful bouts with lower back pain, they might start to lose their faith in us, and that's definitely not setting us up for success. So I put this image here, and if you guys can't see it very well, I will send it to you. But this is from Explain Pain Supercharged, and basically it gives you a nice spectrum of patients' beliefs when they first come into the clinic. So to the left, you'll see a quote that says, "Get stuffed." So when you're trying to communicate to a patient, they already are not buying in. They maybe have some negative belief about physical therapy. Maybe they don't like the facility that you're working in, heard something bad about PT, something, but they're not buying into it. And as you move towards the right, the likelihood that the patient's starting to buy in a little bit more, they might be a little bit apprehensive, but it goes from, you know, I'll give it a try to I'm all in, tell me anything, I'll do anything. They're ready to listen to your message. Now, what I like about this diagram is that it shows that there's this interlacing between how someone who is initially apprehensive might be able to work their way towards being brought into treatment and vice versa. It all depends on all the factors that go into, you know, message transmission as a provider or someone trying to affect change. And you have to make sure that people are continuing to get this feedback that things are going to be okay, that you're providing the right message at the right time. And hopefully the goal is for deep conceptual change to manifest, so that you don't just make something better and then you start the situation all over again because 6 months later they're having back pain again. Although that's quite possible in any situation, you are better off yielding that deep conceptual change so that the likelihood they come back to you is significantly less. So what I just talked about ties nicely into expectation. Expectations are incredibly important. If someone has a negative expectation about their encounter with you, there's a pretty high likelihood it's going to go pretty poorly. You want to make sure that the patient, even if they're a little bit apprehensive, they're at least willing to perceive the message that you are delivering. If they don't perceive the message, it's been shown that you have a greater risk of disability and lower treatment satisfaction. It's probably not very surprising. A lot of these statistics and study findings are not very surprising, but they just sort of reinforce what I'm trying to talk about, that you need to get people to have positive expectations that being in treatment is going to be effective for them, whether it's physical therapy, whether it's a general medicine visit, acupuncture, you name it, people need to buy into what you're selling. And sometimes people have incredibly lofty expectations about what you're doing or what you will do to them, and you have to be a little bit more realistic or redirect them down another way of thinking so that they can have realistic expectations about where they are, where they're going to go over the next few sessions, and it's a constant communication between you and the patient. So tying into expectations, we talk about alliance. The alliance between you and the patient and vice versa is key. I use the example of interferential current here because it just goes to show that even at a non-therapeutic dosage of current, if you have what's perceived in a study as a therapeutic alliance with the client, you'll get better results in terms of pain reduction than if you actually set interferential current to a therapeutic dose and didn't establish that rapport with them first. Now, I would likely not use interferential current with anybody, but if this is something that you do, you definitely want to consider the fact that you need to at least have an established rapport with somebody first. And in order to create an alliance, you have to do a few things. You need to listen. And I'll talk a little bit more about listening actively moving forward. You need to give the right messages. They may or may not parallel with the patient's beliefs, but this is an ongoing emergent process in trying to get people to buy into your message. Should you want to place your hands on a patient, whether it be for manual treatment, whether it be for facilitating cueing through exercise, or whether you felt it necessary to console somebody as you're performing this objective, you want to make sure that you have consent. You want to make sure that the patient is comfortable with where you're contacting them or contacting them at all, because doing so and making the patient feel uncomfortable is not a good way to establish a good alliance. So at the bottom, I put in one of the studies, the setting you work at and your communication style also have incredible importance for patients to buy into the treatment and want to be active participants in the treatment. So sometimes the clinical setting, you really can't control too much, but you can definitely control how you communicate to the patient. And some of that is relative to who the patient is and how they receive information. So you have to try to adapt your method of communication to best meet their needs. So I put a couple of examples from the literature here to talk about perception and why it's so important. Because people who have chronic pain tend to have difficulty perceiving things as they are. And some of us might be duped by this as well. But for example, hot versus cold perception. You have clients who are touched by a bar. It's a steel rod rather. One is colored red and one is colored blue. The temperature of the bar is the same, but every participant was touched with that bar, with the respective colored bars on their necks. And what they found is that people perceive the red bar as being hotter and causing more pain than the blue bar, even though the temperatures were the same. Another one I like talking about is the acupuncture of the rubber hand. So when people had their hand concealed and were seeing the concealed hand in rubber form in front of them, they actually felt pain seeing a rubber hand being stuck with acupuncture needles, even though their hand wasn't in sight. So it just goes to show you that people's cortices are processing noxious stimulus, even in the absence of actual tissue damage. And the rest of them are interesting. If you guys want any of these, I could send them to you. This is a video. I don't know if the sound is going to be okay. I'm going to try it. But basically, this is a good video. I took it from Greg Lehman talking about how perception can be controlled by many different factors. So I'm going to try playing it. If it doesn't work, we'll move on and I can send you the link later. Oh, man. All right, sorry guys. I thought that would actually work. Thanks for whoever chatted. That I didn't want to waste anybody's time. But basically, the moral of that video is that people perceive red and white wine to be different, even though it was just white wine colored red, and people had negative perceptions about white wine before. So sorry about that. I will move on. But thank you for paying attention. So we get to the subjective exam, which I guess we started considering people's perceptions and expectations. Always, 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 whether you're being competent and conscious about the biopsychosocial factors, you want to rule out red flags. Now, I caution because night pain is one of the red flags that is normally discussed in the context of cancer, but night pain is also seen in clients who have chronic pain and pain in general, because oftentimes people are able to focus on their pain at night when they have no other distractions and they're laying on their pillow and they feel pain. Does it necessarily mean they have cancer? No. It requires a more thorough, questioning and analysis to determine whether someone might be at risk for having cancer and warrant a medical referral versus this is something that they just focus on because they have no distraction. And just like we talked about before, beliefs are important. You want to consider lifestyle, health, and social factors. Coping strategies are big, and I'll talk about that a little bit, and emotional and psychological factors. This is also from Greg Lehman via Jared Maynard, but basically, this is a nice little diagram talking about these in more detail. Beliefs are incredibly important. If you believe something is bad, if you believe something is harmful, it likely is going to be. And it's up to you to help that individual figure out how movement can be a positive experience for them. And in anything in general, Ben Cormack actually talked about this, where basically if you believe something is going to work or you believe something is good, it's going to be good. It's going to work. More often than not, there are situations when that's not good enough, but for the most part, when people believe, you can achieve. Talking about lifestyle, health, and social factors, sleep is huge. Sleep is something that a lot of people aren't getting enough of. And if you're more interested in this, I would recommend reading Why We Sleep by Matthew Walker. He delves into this a little bit more deeply, how you can make your room a conducive environment to getting enough sleep by making it cooler, making it darker, limiting screen time, so on and so forth. But a lot of people aren't getting enough sleep, and sleep helps build up our immune system. Sleep helps, connect everything that we learn throughout the day and lead it to memory processing so that we can retain information. But in the absence of, dream sleep or non-dream sleep, we lose some aspect of learning, some aspect of our health. So that's incredibly important. And thinking about coping, there's two types of copers that the research talks about very often. You have avoidance copers and persistence copers. Avoidance copers, in the presence of pain, they will not do something. So for example, if bending forward hurts, they're not bending over to even pick up a shoe, not to pick up anything, a small bag off the ground, not doing it. Persisters, on the other hand, have this more of a no pain, no gain mentality, and they're willing to just fight through all the pain that they feel because they're just not going to give up. They won't let it stop them. But it's up to us to figure out, well, how much load is enough for the avoiders to get over their fears of movement, and how much can we reduce the persisters from doing so that they can find a load that's more suitable to keeping them going. And fear, I would say, is arguably worse than pain in terms of return to sport and ACLs. It certainly keeps people from doing things that makes them healthy, and definitely something you want to address as a provider of services. So listening, something I'm not very good at sometimes because I enjoy talking so much, but it is incredibly important to listen. Your patient is there seeking help, and you are providing a safe environment for them to share their story. And when they're sharing their story, listen carefully. You don't want to be looking around the clinic. You don't want to be looking at a different screen while you're doing the intake. You want to look people in the eyes. You want to sit up nice and tall. If it's, you don't have to sit up nice and tall, but you certainly don't want to slouch over. You don't want to be leaning onto a table. You want to show people that you're engaged, that what they're telling you is valuable and you actually care. Definitely validate anything that they're feeling, whatever they're feeling, whether it's pain or not pain, or not real pain, rather. Pain is real. So I just contradicted myself there. But basically, if someone perceives that pain is real, it's real, whether it's psychosomatic or whether it's actually coming from tissue damage. But definitely respect their platform to talk, and try not to share any opinions about how they feel in the moment, but you can definitely share your clinical input later on. And I think the Homer Simpson image there. I'm hoping somebody's laughing. I can't really tell right now, but hopefully so. So one thing we need to be mindful about is the nocebo effect, which I'm sure most of you are familiar with, but basically the definition is here. Anything that will increase negative expectations about the course of a disease. So oftentimes it's things that we say as well-intentioned providers that helps stir up these negative feelings and might lead patients down this negative pathway. I saw something in the chat. Okay, awesome, thanks. I'm glad you guys are enjoying it. So this is one of my favorite quotes, and I'll leave it here for you just to appreciate, because we have incredible power as effectors of change, that we need to be really mindful of what we're saying, because if we're not, we can really do some damage. But if we are, we can really help inspire some positive change. So feel free to use this wherever you want. I love this quote. I use it all the time. Something that is incredibly important is it's more important to not say bad things than it is to say good things. It's like if you got it right 99% of the time, and everything you're saying, the timing of your message, when you decide to enlist it in a treatment, how loud you are, all those things, great. You're doing a great job. But if you say something that the patient perceives as being bad, or you're throwing some nocebos out there, that will always hold supreme. And it is more powerful to have a negative experience manifest for a longer period of time than a positive experience. So you really want to be mindful that at the very least, don't say anything bad. Even if you're well-intentioned, try your best to stay away from those types of communications. I know many of us, graduate school, we have all this knowledge about tissues and anatomy, and we sometimes on our clinical experiences, we get used to taking out a model of a spine, for instance, or some visual aid on an app, and we talk about what's going on at the spine that's causing people to be experiencing pain. Now, for some people that might be okay, Because some people might say, oh, educate me, I want to know more about it, and there won't be a negative effect. But for people with chronic pain, it's usually not a very effective means of explaining why they're having pain. Something else that you want to consider is that you don't want to ruminate for somebody who's having pain, chronic pain, and they've been feeling down for a while and can't seem to figure it out. Tell them all the positive things that are going on. So for example, with low back pain, say somebody can't lift heavy objects off the floor. Well, can they sit for a decent amount of time? Can they stand for a decent amount of time? Can they lift anything? If they're capable of doing any of those things, reinforce that those are positive things and something that they should be happy about, and use that to help inspire positive movement moving forward. Something else you want to do is, I think I mentioned it before, timing. Telling somebody something when they're agitated is probably not going to go over so well as if they're really bought into your program. And maybe not even just agitated, maybe they're just skeptical, maybe they had a bad day or things are going on in their life. Maybe something that you plan to discuss at that point might have to wait for a later date or a different session because it's just not the right time. So you really ought to also consider like what is going on in the patient's lives in the context of when you deliver a message. Another one of my favorite infographics is here. I don't like when people, I mean, it's understandable when you read things on the internet and patients talking to other people about their backs, hearing the slip disc phenomena, because we know that the spine is really stable, that discs don't actually slip. I mean, even with a spondylolisthesis, it's not the disc that's doing the slipping. So you really have to try your best not to reinforce these beliefs that the disc is slipping. Because when people think about their disc mentally being out of alignment, it might make them a little bit more apprehensive to move. So instead, what you want to tell people is to be active, but be careful. So saying that, okay, well, even if you have tissue damage, you're still capable of moving. Something I like to use in the context of communication are metaphors. Metaphors make pain and dealing with rehab a little bit more fun. And this is something that David Butler talked about in his course that I took. You kind of want to make light of a dark situation. So for example, if someone compares, I had a client from the UK once, and she talked about how her pain was making her feel a little bit like a lemon, which made no sense to me at all. But for her, it was making, light of a dark situation. She was in pain, but whatever a lemon felt like to her was definitely better than just being like, oh, this pain is hurting me really bad. She's trying to make something positive from something negative. So I'm sure plenty of you guys have experiences. Maybe you have your own metaphors that you use or clients have used with you. I'd love to see some of those pop up in the chat as we go along. Is that we have one? I'll have to read it later, but definitely I think metaphors help cast a positive, fun, loving spirit over something that's not so positive. So so if you're not familiar with the concepts of peripheral and central sensitization, basically peripheral sensitization is everything that's not including the central nervous system. So basically your nerves versus your brain and your spinal cord, your nerves and every other aspect of the peripheral nervous system. So astrocytes, glial cells, so on and so forth. When people have peripheral sensitization and cortical changes haven't manifested fully yet, one of the big differences is that they're going to be a little bit more sensitive to heat than cold, versus when you have central sensitization and you have a lot of cortical changes in the brain, meaning that like your prefrontal cortex where thoughts and planning and all that stuff is happening is smudging over the somatosensory cortex. Then you have all this rewiring that needs to happen, usually a little bit more sensitive to cold, among other things, which I put here. So if people talk about these things in their intake, something you might want to consider that, okay, this is central sensitization versus peripheral. So we have a job, whether it's I put physical therapists here, but if we have people from other disciplines, we all have a job working successfully with patients who are experiencing chronic pain. We know from evidence that educating people about pain is more successful at reducing chronic pain and disability than Lyrica, which is a commonly prescribed neuropathic medication. If you're not familiar with NNT from the research, NNT basically means number needed to treat. So in this particular case, for every 3.5 people, which I don't know how 3.5 happens because there can't be half a person. For every 3.5 people that were given pain education, one had a significantly effective change for pain reduction versus Lyrica, where you need to prescribe Lyrica to about 10 to 12 people. So if you think about the amount of money spent on medication, the fact that medication is a passive treatment, significantly more people needed to be seen in order to have an effective change with Lyrica. And we know now more than ever that modifying the personal and environmental factors in people's lives are considerably important in reducing disability. So to the left here, we have dim sum. For those of you who don't have dietary restrictions, once this quarantine is lifted, I highly recommend you go get some, because I know that would be one of the first things that I do. So basically, dim sum turns into dims and sims, which is the concept used by David Butler and Lorimer Moseley, basically that dangers in me versus safeties in me. Dangers in me are things that I perceive as being harmful. So maybe I have a lot of job stress, I have a lot of marital stress, worrying about finances. Those are dangers in me. Those are things that will manifest negatively in my pain experience versus safeties in me, basically like social support, exercise. Those are things that make me feel good and build up my capacity to deal with pain. I might as well just have stolen all of Greg Lehman's content, but basically thinking about everything we need to do, everything that can contribute to a pain experience under an umbrella. These are the things that we have to consider when patients are coming up with DIMS and SIMs, and what we need to modify so that people can load themselves in a constructive manner to affect change. Some example I use quite often is the cup model that Greg Lehman uses. Basically, the contents of the cup are all the negative factors that can contribute to our pain experience or negatively impacting our capacity to manage pain. The cup would be our capacity to manage pain. Now, you can either tell someone to build a bigger cup and basically increase their resilience to dealing with all the negative factors in their life, or try and flush out some of the contents of their cup so that they can maintain a nice balance. For those of you who aren't familiar with Explain Pain or have not taken the course, first of all, I highly recommend taking the course. It comes around to New York quite often, but it's global. This is called the protectometer. So if patients need a visualization of what DIMS and SIMs might do to them, this is a nice tool to use. I know some settings don't allow us to use this. I don't use it very often, but once or twice there might be a client who can benefit from going through this weekly. And basically what you're trying to do is get the protectometer to move as far away from the head, so towards the feet, even though there's no feet here, as possible. Basically trying to turn your DIMS into SIMs so that you can lower the indicator. And there's another set of exercises that Butler and Moseley use in order to help figure out what DIMS and SIMs are. All right, so we've taken all these things into consideration about the subjective examination and helping people understand pain science a little bit more. So what does that mean in the concept of prescribing movement and it really trying to manifest change in an individual? First, we need to consider why an individual might be fearful of movement. I get all the time people saying, I'm willing to do anything you tell me as long as it doesn't make it hurt. The problem is nobody has a concrete answer on how to make that happen because there's too many variables, as we know, to each individual. Like no two individuals with low back pain are made equally. So therefore one needs a certain type of load and another needs something completely different. So we don't know what's going to make it worse. Individuals who are having very low levels of self-efficacy, it's going to be a little bit more difficult to get them motivated to exercise. They have to believe that they can be in control of their bodies, that movement is going to be something positive for them. Then you get the people who, oh, you know, I have kids at home, I have all this work stuff, the gym is too far, it's raining, so on and so forth. They come up with all these possible barriers to exercise that they won't even try. So you have to consider that and help people navigate those barriers. People in that context might come to you and they might not understand exercise at all. Exercise might not be a part of their daily routine, or not their daily routine, even their regular routine. Or they tried exercising before with another physical therapist, maybe they tried CrossFit and they had negative experience with CrossFit. I don't know, but all those things, something to consider moving forward. When I do talk about CrossFit, I don't say that CrossFit is all negative. One thing they do very well is create an amazing support system. Just like many other group fitness activities, having support is really critical in helping you get through chronic pain. Not having that is definitely going to make things more difficult. And it goes without saying that anxiety and depression certainly, although there have been positive outcomes with exercise in this population, it can certainly lead to a little bit more apprehension to exercise. So if exercise didn't help, all of us are wasting our time giving it to people. We know that it helps. We know that it does so many positive things to people, not even just physically, but emotionally, psychologically, you name it, exercise helps. What isn't as important is the type of exercise you give to people. There was a systematic review that just came out about lower back pain, and basically, you name it, that exercise was on there for being significantly effective in dealing with low back pain. But more specifically, stabilization training, Pilates was on there. I'm trying to recall some of the other ones, but there were quite a bit on there. And one concept that I'm going to get into a little bit is that exercising with a little bit of pain can actually be quite helpful. So keep that in mind moving forward. How many times have I said moving forward? Probably too many. I need to find a new transitional set of words. However, exercise is not always the answer. Though exercise can be helpful, maybe some individual might not need exercise at a given time. Maybe they need a little bit more coaching and education first. Maybe, although not ideal, you do a little bit of manual therapy as a means of facilitating exercise to be effective. So though exercise is helpful, it's not always. And what I put to the right, which is concept of regression to the mean, I found this quite interesting, that some individuals will just get better just by doing something. It doesn't have anything to do with the fact that this exercise did it, but just the fact that they're doing something is helpful enough. So I'm sure most of you are aware of that, or if you're not, that is what regression to the mean means. So the concept in which I operate with for chronic pain patients that came from the literature is graded exposure. Basically, what you want to do is exactly what graded exposure says. You want to gradually introduce activities that were once deemed fearful, that are likely to be painful, so that they can build an overall resilience over time. Basically, what you are doing with movement is creating the somatosensory cortex, and actually brain as a whole. You're correcting its error in judgment based off all the information it's getting from the periphery and what has been stored in the brain. People who are in chronic pain are getting very false information about what's dangerous and what's not. So what you're doing by gradually moving them into those movements and under loads that they have been avoiding for so long, the brain is able to adapt. Remember that we are bioplastic and that pain is just an alarm system. We're capable of gradually exposing ourselves to greater ranges of motion, greater loads over time because our body adapts to stress. And why this is important is because of I think it's so nicely depicted in the 2 Peaks model by David Butler. So basically, if you think about a mountain, the first time you climb up a mountain before you feel pain, you can get pretty high up before your body's going to say, okay, we're starting to feel sore. And if we keep going higher, our tissues are probably going to fail and you're going to hurt yourself. After you feel an injury, you can still climb up that mountain. But that initial response to, okay, if you go up any higher, our tissues are going to hurt, it's going to present much, much faster. So what we're trying to do with graded exposure is to get that protect by pain line closer to the tissue tolerance line again. I'm sorry about the traffic light model. It looks like it's not showing up very well, but these are two images that I use. Sometimes I use the images, but sometimes I just explain them when explaining to patients why pain during exercise can be not only effective, but quite important. They talk about the traffic light in terms of tendinopathy research quite a bit. So basically, if you have 0 to 3 out of 10 pain, green light, pedal to the metal, you keep going, no regard for mankind or human life. So the exercise is fine, keep doing it. It's when the exercise gets into the 4 to 5 out of 10 range where you just have to start reconsidering, you have to start proceeding with caution. It doesn't mean you can't do a particular exercise, but you want to be mindful of that pain, which is totally subjective, and the patient is communicating with you as they're doing the exercise on how much pain they're feeling. Because if it gets to 6 to 10 out of 10, you want to try to modify it so it goes back down, or you want to cease it altogether. And what we're looking for is not a residual increase in pain right after or the next day. You want to try and find that dosage that's going to be just right, which ties into the Goldilocks principle. We're always looking for the right temperature porridge. Hopefully you're familiar with Goldilocks, otherwise this will probably go right over your head. If people are not sore or in pain at all after an exercise, you have to start thinking, okay, well, did it challenge them enough? It might have, it might not have. If they're in worse pain or they feel incredibly sore for an extended period of time, you likely challenge them too much. You need to modify what you've given them. But if they feel a little bit sore and their pain is probably the same, I'd say you're doing just fine, especially if the movements that they're doing are getting more complicated. They're able to hold them for a little bit longer. They're able to lift more weight. Those are all positive things. So if they're feeling the same in that circumstance, totally fine to continue. So like I mentioned before, exercising into pain is quite useful. It's good for demonstrating this concept that hurt does not equal harm. Again, pain is just an alarm. We have fears of movement, me included, sometimes when I feel pain that I'm hurting myself, but it's just an alarm. And it's about modifying the activity in order to affect change that's not going to elicit such a negative alarm, such a massive alarm signal. So for example, when patients have a flexion intolerance or they're fearful of bending forward, one of my favorite things to do is to put them in child's pose. Because oftentimes patients who have trouble bending forward can sit considerably far back in a child's pose. So it doesn't necessarily mean that their spine can't flex. It means that it's intolerant against gravity. So when you change the context, people can see that their spine is still capable of moving, just not against load. So use different contexts, different weights, modify activity so that people might feel a little bit of pain, but they're capable of doing it. And over time, they'll be more successful. So if you guys had any questions up to now, I will stay on after and address them. Otherwise, you can write them in the chat. But I'm going to leave this here for about 2 minutes for everyone to read. and I have some questions at the bottom, which we can talk about, and then I'll switch back to the screen so I can see you all, interact with you all, and talk about things a little bit further. Okay, let me come back here. Okay, let's see in the chat, motion is lotion. Yep, that's a great one. I use that a lot. Okay, any questions about the case study? Any questions about what I discussed? Or most of you are already familiar with it and you're just supporting me because I'm a good guy and you want to do good things for a good guy. Aaron, I really appreciate that feedback, man. Kevin, same to you. More positions to use with patients. Alan, are you talking in the context of lower back pain or just in general? General, okay. So I always think, okay, so if, I'll give you another example. So let's talk about squatting. Squatting is one of the most easily modifiable activities that you can do. So if someone can't squat to depth, meaning they can't get their butt to in line with their knees, what I would do first is do it with an assist. So if you have a TRX, if you have a sturdy doorknob, if you have a pole to grab onto, I would see if the individual can achieve that depth with some support. If they still can't, I might maybe do a squat on a box and have them just do it in a shorter range and progressively challenge them that way. And if you want to talk about other ones, feel free to message me anytime. I can address those. So we had a good question about neck pain and lower back pain that seems to alternate from side to side. A lot of that is dependent on the triggers. So for example, with your neck, if it's twisting that bothers your neck, it might be a little bit more, it might be different to work with that versus bending up and down. So in terms of bending up and down or twisting, the best thing for necks, I would say, is do it resting on a pillow first. See if you can achieve that movement rested on a surface. Then what you might want to do is progress it to against the wall or putting a ball on your head, on the back of your head, and so on and so forth until you can actually do it against gravity. Same thing with the low back. It's just all about doing things supported and then doing them against load. Yeah, if you have any more questions about this, feel free to reach out to me at any time. We got another question. How'd you educate a patient on pain signals? That's a good question because sometimes people think I'm full of shit when I say that. So first, this would be the easiest thing if you had an explained pain book, just to show them that pain is just an alarm. I think talking about tissue damage and pain not correlating is a great place to start, because then we know that, okay, well, if there's nothing wrong with me, then why am I feeling pain? And using that as a means of being like, okay, there's no actual danger, but for some reason I'm feeling pain. I think that's bare bones my best approach to that I can think of right now in terms of communicating that to a patient. Anything else? Yeah, no, for sure. These questions are great, and I love talking about all this stuff. So this is great for me. All right. Well, if you guys don't have any other questions or you don't want to talk about the case study at all, I'm going to stop recording. And if you want to stay and chat afterwards, that's fine. Otherwise, I really appreciate you all for being here. And we'll stay in touch. If you guys want a copy of this, I can get this to you. Otherwise, be on the lookout for more webinars. For me, I'm in the process of coming up with one for how to deal with staying healthy at home during this time. And I'm trying to collaborate with someone with a nutrition background on that. So stay tuned for that. But thank you all, and I hope to see you guys around.